Welcome back to a special mini episode of Cancer Buzz. I'm your host, Summer Johnson. Today, getting paid for the services you provide, billing and coding for cancer care. What you need to know is next. Accurate coding and billing and staying current with payer updates, exceptions, policy changes, and the latest proposed and final Medicare payment rules all directly impact cancer care providers' ability to stay in business and deliver high-quality care for their patients with cancer. We tapped today's guest for tips to keep up with this constantly changing, complex facet of cancer care delivery. Teri Bedard is Executive Director of Clients and Corporate Resources at Revenue Cycle Coding Strategies in Des Moines.
In order to keep those doors open to treat our patients, we have to be able to make sure we're generating that revenue. So we have to know billing, and it's everybody in the department. Even if they say, I don't put the charges through, if they're providing services to the patient, they need to know about billing and some of the rules and guidelines and their role in it, because we can't treat our patients if we don't have that revenue coming in to keep everything open. And it's really just the cycle that goes through.
So let's talk about supervisory oversight requirements. Can you clarify when direct supervision versus general supervision is required?
In the hospital setting, general supervision right now is the requirement per Medicare. That was established January 1st of 2020, and that has been through the pandemic as well. For those in the office setting, it's still direct supervision. And even the AMA CPT manual states, things like chemotherapy and administrations are under direct supervision. So it really depends upon the setting that you're in, what services you're providing. Everything we do under oncology is therapeutic. So you're either general supervision in the hospital or direct supervision in the office setting.
How is personal supervision defined, and when is that required?
Personal supervision really requires the physician to be in the room, in the office suite, actually at the location, whether it's the console providing, supervision is where they are in relation to their staff. So personal supervision means the physician has to be right there next to their staff that are providing these services. We don't have a lot of things that are personal supervision that have been assigned that, although from a regulatory standpoint, we think of brachytherapy stuff in radiation oncology, that does require the personal presence of the physician. It's a little different and it kind of falls outside those guidelines. But personal supervision, we used to have some services in the oncologies. Right now, we're really more just general or direct supervision requirements to those services.
What about hybrid?
Well, hybrid, that is where, initially the patient, we could start them with the physician present, being available. And then as the patient was, stable, things were doing okay, the physician could step away and they could continue that non-surgical extended duration service under that general supervision. And since then, Medicare has actually shifted everything to general supervision for those non-surgical extended duration services. I think what gets confusing sometimes with supervision is that's where the physician has to be physically in relation to their ancillary staff who are working under their direction. The physician, if they're actually billing for work, they do have to personally be present doing that work. So there is a little bit of a misconception or a misunderstanding of when we say supervision, it does really pertain to where they are physically with their staff. And then separately, they have to do their own separate work personally there as well. So it gets a little confusing, I think, sometimes.
What about advanced practitioners? Can the direct supervision be provided by them?
It depends. It really comes down to their state scope of practice. It comes down to the granted privileges, whether it's in the hospital. It depends on who employs them. So if they're part of the physician group and it isn't within their state scope of practice, they've been trained in it and it's under their granted privileges, they could provide that supervision. If it's not, then no, they would just be working as similar ancillary staff, under incident 2 to that physician, and they may or may not be able to be the ones providing that supervision themselves. So they may actually be working under directly that physician instead.
So we've been following, of course, the changes and the temporary exceptions for COVID-19 on this podcast. Are there any COVID-19 exceptions or waivers related to oversight that are due to expire?
Right. And we're looking at, right now, we're waiting to see if that public health emergency is going to be extended through the end of the year. We anticipate it will. That's kind of the words we're hearing, but we'll still wait to see what happens. But yes, so for right now, direct supervision in the office setting can be provided by that real-time audio video capabilities. So the physician doesn't have to have a Zoom meeting going the entire time of that day. But if there's something, where a patient comes in and the staff is like, I really need the physician to be observing as we're doing this, as, they're not able to be there, they could do that through that real-time audio video. Once the public health emergency ends, we expect that that's going to transition back to where we were back in, February of 2020, prior to the pandemic being established and these waivers being extended. And it will be in person in the office suite, providing that direct supervision.
How do you recommend to oncology professionals to keep current with these guidelines and changes?
Yeah, it's difficult sometimes because there's always stuff that seems to be happening and coming out. I think ACCC does a really great job of providing resources and making sure that people can get access to them, some of the alerts. It's really kind of understanding and knowing who are some of the societies that provide some of that information. And, my company as well, we do provide summaries and answer questions. We provide some support to different organizations. And so I think it's knowing the timing. Medicare gets ready to release what they're going to do in July. If you haven't heard what's going to happen for the next year by, mid-November, start looking, start Googling. It's easy to find some of that stuff, but start reaching out to some of the specialty societies that you are maybe participating in, can ask those questions, because there's so much information out there. Even sometimes for me, it's difficult to make sure I'm staying on top of everything and finding everything. And that's my main job, is to make sure that I'm reading all of that information.
You can find more resources related to today's conversation in the show notes. Thank you for listening to Cancer Buzz. Follow the show on your favorite podcast app to be notified as soon as fresh episodes are posted, which is often. And if you've been enjoying the information on this Cancer Buzz audio podcast, be sure to check out the brand new Cancer Buzz TV channel. Just search for Cancer Buzz TV on Apple Podcasts. Until then, for the Cancer Buzz team, this is Summer Johnson.
Cancer Buzz is a resource of the Association of Community Cancer Centers.